Whenever any adolescent comes with any of these following complaints of hirsutism, treatment-resistant acne, menstrual irregularity, and obesity, please do consider that she is in need of something. And we all understand yesterday the whole lot and very brilliant, experienced professors have given you the pathophysiology, and we all know it is not an easy thing. It is a complex triad which involves two hits: congenital predisposition hit and the postnatal provocative hit. So you cannot blame only a single thing. It has got sometimes both, sometimes the single factor into it. So heritable traits and gene variants affecting the ovarian functions, or they are predisposing to insulin resistance. So yesterday somebody was saying what is hyperinsulinemia. So it can be postnatally can be acquired, or it could be the fetus is born with the programming of it because of the mother was GDM or something like that. Congenital virilization and disturbed fetal nutrition. We had a long talk yesterday over this and emphasis was given to it. The postnatal provocative hit is insulin-resistant hyperinsulinemia, metabolic syndrome, and postnatal obesity, and puberty itself brings a lot of changes into your body, and certain things can break down at that time. So we have to be very cautious and puberty is very important time. So this is one of the model for the pathophysiology of the PCOS is being given. It is the pathophysiology in which we see the pituitary is going to secrete the FSH and LH, which is going to act on the theca cell and also going to cause the oligoanovulation and also going to cause the hirsutism. But in the meantime, there's a insulin resistant hyperinsulinemia is also there, which has got effects on which causes the obesity, and it has got an effect on the theca cells, which plays and which improve or worsens the androgenic milieu of the woman, that adolescent girl, and it causes the increase in the FS secretion of the LH, increase in the LH secretion from the pituitary. It also causes into the granulosa cells, the luteinization of the cells, and it also causes the hirsutism. This luteinization of the granulosa cells is caused not only by initially because of the hyperandrogenic situation, or it is insulin resistant hyperinsulinemia directly, or it is going to worsen the hyperandrogenism and going to cause this, and because it is the follicle is not happening, the folliculogenesis is not going to be mature, so there is a constant secretion of the estradiol and it causes the suppression of the FSH. So because the FSH is suppressed, so it leads to the vicious circle, because it is folliculogenesis is not occurring properly, so the estradiol is not giving a negative feedback to the pituitary, and so it is FSH is being suppressed, and obesity itself is causing the vicious circle for this milieu. So this is the unified minimal model for the PCOS. It happens in the 5 stages. The functional ovarian hyperandrogenism is universal and accounts for all cardinal features: hyperandrogenemia, oligoanovulation, PCOM, pituitary LH axis is necessary to sustain the ovarian change. Mind the word that it does not cause axis, but is the LH axis is necessary to sustain the ovarian androgen axis, but is not sufficient to cause it. That is what I want to emphasize. In the step 2, there is an abnormal degree of insulin resistant hyperinsulinism, acts on the theca cell to aggravate hyperandrogenism, synergizes with the androgens and premature luteinization of granular cells, and stimulates the fat deposition. In the step 3, the increased hyperandrogenism provokes LH axis, which acts on both theca cells and luteinized granular cells to worsen the hyperandrogenism. Step 4, the LH also stimulates luteinized granular cells to secrete estradiol, which suppresses FSH secretion and aggravates PCOM, not the PCOS. The step 5, the hyperinsulinism initiated changes in granular cells function further exacerbates PCOM and hinders the ovulation. Obesity increases insulin resistant and resultant hyperinsulinism further aggravates the hyperandrogenism. But this unified model does not explain the other intrinsic factor which may be present in the ovarian function and the cause of this oligoanovulation. So this is not a perfect model, but it explains a lot about the PCOS pathology, not the other pathology. So clinical features, we all understand that whenever the cutaneous signs, hirsutism or moderate to severe acne or the menstrual irregularity present, In the imaging, you get PCOS morphology, obesity and insulin resistant. We know that she is a case of PCOS. So for the diagnosis, you have to see the menstrual history. I am not going to detail of the menstrual history, the past medical history, review of the symptoms, family history, and mind the word social history is also very important, because sometimes these things are happening because of the stress and the social factors also. So social history is very important. So if you want, you can go through. I am not going to say everything. So these are the things which ideally you should ask. The review of the symptoms is also very important, because bruising and epistaxis is important to rule out the coagulopathy, because many of the times I know, because I keep on getting these kind of the patients who are being treated at the periphery, not being getting right kind, or cannot be get managed or cured. So they come to us and we see that von Willebrand disease is not a very uncommon disease, and we get many patients, many adolescents for it. So you have to see, you, my only message by this is that everybody should treat, but if they take some time, but if they are not getting to the cause or the cure, please refer it to the institutions which are dealing with the specialist things. So this is the better way to get your patients better management, and they will come back to you and they always appreciate such and such doctor has referred me to that doctor. So I can say that because of that doctor who referred me, I am not cured. So the credit goes to the person who has made an early diagnosis and has given the right kind of the consent and advice. So these are the vital signs. I am not going to see that what you have to see. You have to see all this whenever the woman is coming to you. So this is the normal menstruation occurs. We all understand normal menstruation is a complex process of hypothalamus, pituitary, ovarian and uterine axis. And we understand that before the follicular maturation, the estradiol is important. Estradiol rises, FSH increases, and as soon before the rupture, there is a LH which is going to increase, and after this thing, progesterone is going to increase. And you can see that as the estradiol is going to go down, the FSH is going to increase. But because of the anovulation, this does not happen into the PCOS, and that is how we do not get the right kind of the situation. So normal menstrual cycle, this is also confusion. When I went through, although I was always listening, but here I should say that people are having different ideas about the normal menstrual cycle, 21 to 35 days, 24 to 38 days, 25 to 35 days, or 28 to 35 days. Various school of thoughts are giving various this thing, but duration and the median blood loss almost same everywhere, and mean cycle length 34.5 days is also been given, and mean duration of flow is 5.4 to 4.5 to 5.4 days. So but usually we accept 24 to 35 days. So this is how you can say that your child who has come to you, in which stage and how you should label it, that what type of the menstrual irregularity she is having. So lack of menarche by the age of 15 or by 3 years after the onset of the thilarche is, you should label it as a primary amenorrhea, because it may be having the different causes. The secondary amenorrhea, if more than 90 days without menstrual periods in a previous menstruating girl. Oligomenorrhea is all depends how many years she has passed post menarche. So if she is having a post menarche year 1, the average cycle length is 90 days, and fewer than 4 cycles are happening. If it is more than 2 years post menarche, the cycle length is decreasing and the cycles are increasing. 3 to 5 years, again it decreases, but if after 5 years she has not improved and she has still having less than 9 cycles per year, we label it now as a PCOS and the case of anovulation. So excessive bleeding is also one of the factors which you can see that sometimes it occurs, and most of the time it is a cause because of the unopposed estrogen secretion. But to label it as excessive bleeding, the definition says it is bleeding more frequently than 21 days or is heavy or prolonged, lasts for 7 days, and pads are soaked, one pad or tampon within 1 to 2 hours. So this is how the chart shows that at the extreme of the ages and in the puberty, it takes some time to settle down. From here and gradually the cycles becomes regular. This thing, how all symptomatic and ovulatory girls are how they are going to settle down in the future. The few are going to be non-hypoandrogenic and ovulatory. Hypogonadism is the common cause for it. And hyperandrogenic, some are going to be hyperandrogenic and anovulatory. PCOS is the commonest cause for it. Sometimes why I want to show this chart, because sometimes you are in a pressure or in a confusion that it is going to say that whether I should give, I am not going to compromise with her pubertal growth. So you can see that pubertal growth is between 10.5 to 12.5 years. It is not, it's all growth in the girls have occurred like this, and after 14.5 years they are hardly having any growth. So pathophysiology, as I have already said, it is anovulation, immature HPO axis, adolescent with irregular or regular cycles can be there, sustained acyclic estrogen secretion is there, estrogen breakthrough bleedings are there, and maturation of HPO axis with time leads to gradual change in ovulatory cycles and the regular cycles, as we have seen in that graph also. So this is an ovulatory AUB. It could be mild, moderate and strong because the time constraint. I am not going to go into the detail of it. This is only thing is when we should say what are the menstrual parameters to say that what should be the frequency, what should be the regularity, and what should be the duration, and what should be the volume of the monthly loss, to label it that what should be the normal and what should be abnormal. So causes of abnormal bleeding, as we have already said, that anovulatory uterine bleeding related to immature HPO axis as the onset of menarche is the commonest cause in adolescent, and unpredictable timing of bleeding and variable amount of flow. Other causes can be there, and you can go through when you are going to the PCOS. So what is the take-home message? The take-home message is knowledge of the menstrual cycle in adolescent, pattern of post-menarche menstrual cycle and time taken to mature HPO axis before jumping to the conclusion of AUB PCOS in adolescents. Good history and examination will help in making the diagnosis and in further management, or making a differential diagnosis, which is more important, because yesterday also somebody was saying that it was the case of acromegaly, but she was treated on the lines of PCOS, and then something has happened, she was pregnant and all those things. So lifestyle and nutrition plays a big role. Please don't forget that the girl should not be allowed, you should watch once she starts gaining weight. Once she is 46.5, it is very difficult to treat. But once she is on the higher side, so make a habit or educate your people that they should have a habit of taking the weight. So they know that they are increasing their weight. And do remember that anovulation is main culprit for the adolescent AUB and PCOS. Close observation and follow-up can reduce the stress, anxiety, and apprehension of adolescent and family. Early diagnosis of AUB, adolescent PCOS, and the different differential diagnosis.